Most conversations about prostatic calcification start from a very simple assumption. There is calcium. Calcium hardens. Hard things block soft systems. So if you remove the hard thing, the system should feel better. That sounds reasonable. Almost too reasonable. But then you look at what actually happens to many people. The calcifications are treated. The scans look cleaner. The stones are smaller, fewer, or no longer concerning. And yet, the discomfort lingers. The pressure doesn't fully leave. The urinary flow doesn't quite return to what it used to be. Something feels unresolved, even when the visible problem is addressed. That's where the question begins to form. If prostatic calcification were only a matter of calcium deposits, why doesn't removing the deposits reliably restore comfort and function? This is usually the moment when discussions get louder, not deeper. More treatments. More methods. Stronger interventions. As if repeating the same framing with more force will eventually make it work. But there is another way to look at it. Instead of asking whether the stones are gone, it might be worth asking what kind of environment allowed them to form in the first place. Calcium does not randomly crystallize inside healthy, well-perfused, low-stress tissue. It precipitates where flow slows down. Where fluids stagnate. Where inflammation quietly persists long enough for the tissue to change its behavior. From that angle, prostatic calcification starts to look less like a cause and more like a marker. A marker of something that has been unfolding upstream for a long time. This leads to the second question, which is more uncomfortable. Is prostatic calcification the thing that causes inflammation, or is long-standing inflammation and local circulation dysfunction the condition that eventually gives rise to calcification? Once you ask it that way, the timeline flips. Inflammation no longer needs a stone to begin. Reduced microcirculation can exist quietly, long before imaging shows anything abnormal. Local signaling can weaken. Cells can shift into a conservative, low-efficiency state simply because the environment stops supporting normal exchange. In such a setting, ducts don't drain well. Secretions linger. The tissue adapts, not to heal, but to endure. Calcification, then, may be what remains after endurance has gone on too long. From this perspective, treating the stone is not wrong. It may even be necessary in certain cases. But it doesn't automatically address the conditions that shape the tissue in the first place. Which explains something many people struggle to put into words: why symptoms can persist even after successful treatment. Not because the treatment failed, but because it was aimed at the residue, not the process. In the framework of Theory X, function is not governed by structure alone. It emerges from the coupling between blood flow, signaling molecules, and cellular metabolism. When that coupling weakens, tissues don't immediately break. They adapt. They slow down. They compromise. By the time calcification appears, the story is already well underway. So perhaps the more useful question is not whether calcification should be removed, but what its presence is quietly pointing to. Maybe prostatic calcification is not just something to eliminate, but something to listen to. A sign that the local biological conversation has been strained for too long. And if that conversation hasn't been restored, then removing the punctuation at the end of the sentence doesn't change the meaning of what came before it. That may be why, for some people, relief remains partial. And why the real issue often feels just out of reach, even when the obvious problem has already been addressed.